now moving back to clinical stuff, we're going to talk about metastatic prostate cancer. And to help us, Lisa Pickering, who works here in London, she's a medical oncologist, unlike Peter Kirkbride, who's a clinical oncologist, deals with radiotherapy and everything else. Lisa, you're a medical oncologist.
I am, yes, I am.
So what Lisa's going to do, and you might look at the programme and say, well, there's a bit of overlap here. She's going to talk to us about metastatic prostate cancer, and it's a didactic talk. It's all the facts that we need, because when we come back after lunch, the plan, I believe, is to liaise with the other speakers.
So indeed, exactly. So thank you very much for asking me here. So exactly like that. What I'm going to do now is spend around about 40 minutes running through some facts and figures and quantitative research. I shouldn't try and use words that I don't normally use. I'll stick to my own terminology. About how we treat patients, men with advanced prostate cancer. It does look on the programme like there may be some overlap with Rob Jones and Ronan McMenamin's session this afternoon. But in fact, we've been liaising with each other, and the way we're running it is there's no interactive pads of questions in my session. I'm some facts and some figures and questions if you like. And then this afternoon, Rob and Ronan are going to use some of the facts I've used, and their session is entirely case studies and questions, and so we sort of mixed it up that way, so it won't be repetitive. So I guess one of the thoughts I was having when I was listening to Claire's talk is that these two are they're quite different talks, and it really sort of highlights the sort of the skill of the job that all of you and many of us are doing as clinicians treating people with prostate cancer. You're trying to understand the biology and the drugs and what they do and why they work, and deal with the actual impact that has on the men who are going through who have the disease all at the same time. And I've sort of divvied my talk up with something about hormones, something about the queries around hormone therapy at the moment, and then something about the newer drugs we're using as well. Now, this isn't talk about epidemiology, but I put this in as a reminder. This is the top 10 causes of all death in men in the UK. So this isn't just cancer-specific death, but the top 10 causes of death of men in the UK. And it's from the Cancer Stats website, which is a fantastic resource of numbers and pictures like this. And I don't need you to I don't need to tell this audience that prostate cancer is a very significant problem, but prostate cancer is a very significant problem and men die from it. So, a few facts about advanced prostate cancer. So the median survival with advanced prostate cancer, it's a number of years, and we see that in our clinics. We are fortunate that we can keep these men who with advanced prostate cancer living for an amount of time, but often, and too often, not as long as they or we would like. Major sites of metastatic disease are bone and lymph nodes, but of course it does affect many other sites as well, and that does have some impact on the drugs we use. And then what I'm going to come on to talk about is the main types of treatment we use, so hormone therapy, cytotoxic chemotherapy, and some of the additional and novel therapies. We know that androgen deprivation works in most men, so more than 90% of men it's first-line therapy. But then it stops working. And Maximal Androgen Blockade works at that time for some, but not many patients. What I'm going to come on and talk about is what is Maximal Androgen Blockade and why we use it. And then chemotherapy, which does improve survival for men with castration, that word again, and I'm going to come on to talk about castration-resistant prostate cancer, with some toxicity, which it often surprises me how well tolerated it is. That is not to say it's important not to minimise the toxicity of chemotherapy, but I'm constantly amazed, having treated other cancers, that men, quite elderly men, can tolerate Docetaxel at times. It does have important toxicities, and it's very important to bear that in mind and to stop treatment when you are not helping people. So some of the questions that I'm going to come on to address. Is androgen deprivation with LHRH analogues, is that optimal first-line treatment? What's the optimal treatment when people fail first-line androgen deprivation? And as soon as somebody progresses, should they have Docetaxel? That's become the mainstay of progression at that point in time. Is that the right thing to do? And what do you do when that now mainstay fails? So that's the sort of things I'm hoping to cover in the next 35 minutes or so. So I thought I'd start with the kind of tricky brain bit, the sciencey bit. You can see I'm not really doing my Jennifer today, but there we go. Within the prostate cancer cell, so this is the crux of the problem. This is what's going on. Try to point, I don't know if I can manage the pointer. So on the far left of the diagram, there is testosterone circulating around men's bodies. This is what it does in the normal situation. This is not prostate cancer. This is, well, this actually says it's prostate cancer. It could be, but it doesn't have to be prostate cancer cell. That testosterone works its way into prostate cells, be they prostate cells or prostate cancer cells, where it's converted into DHT. Right? All we say is to DHT, and that DHT binds to an androgen receptor, and that molecule, that mixture of DHT and androgen receptor, worms its way into the nucleus of the prostate cell or prostate cancer cell. It binds to the green bit, the DNA, and that triggers transcription. And what that means is that makes those cells grow and multiply and grow and multiply and grow and multiply. So testosterone feeds the ongoing growth, multiplication, and division of prostate cells. So this is the picture that we're all used to seeing. This sort of feedback loop, hypothalamic, pituitary, gonadal axis. And it is important, and I think for this audience, just having a little look at it is useful. And what I'm going to do is pick it apart and just look at what I think are the important parts of it. So rather than looking at it in a whole like that, where it just makes me think of biology A-level or something, which is not necessarily a particularly pleasant memory, I think we just need to think about what's important about that and why it's useful to think about that when we've got men in front of us who to whom we're going to be giving treatment. This is the aside. Within that picture, if I go back, there is this bit about the adrenal glands. Actually, they are important, but for the first bit of this, they're not that important, so we'll put those to one side for later, and until later. And what we'll think about first off is what goes on in the brain. So the key bit is that the hypothalamus makes LHRH, which goes to the pituitary, and the pituitary gland makes luteinizing hormone, LH. And that circulates around the body where it finds, amongst other things, the Leydig cells within the testicles, which make testosterone. So that part of it explains most of what's going on. In the normal setting, no drugs, no orchidectomy, no surgery, no nothing. The brain is feeding, by the action of LH, testosterone production from the testicles. And that's the most important bit of all, because the testosterone goes to the prostate, as I showed you on the previous diagram, and feeds prostate cancer cell, or normal prostate cell, but if there are cancer cells, they're prostate cancer cells, growth and division. And that's what this slide says. So serum testosterone feeds prostate cells, but if one of those cells has gone wrong and turned into cancer, and I think probably for the sake of time, we're not going to try and cover what makes a cancer cell, but if that cell has gone wrong and become malignant, then that same testosterone is now feeding increased proliferation or growth of prostate cancer cells. So, back to the diagram. What I've added in on this one is on the left, the testosterone. So if you've got testosterone in the body, there is what we get referred to as a negative feedback loop. And the way that works is, if you've got testosterone, that tells the brain there's lots of testosterone in the system, so you don't need to keep making too much. And so the more testosterone that goes into the brain reacts to that and thinks, I don't need to make too much testosterone now, there's loads floating around, I'll shut down a bit and stop pumping out LHRH and LH. Whereas, if there's not very much testosterone, the brain detects, oh, there's not enough testosterone floating around there, I better start chucking out a bit more LHRH and LH, and that will go back to the prostate, go back to the testicles, which will make more testosterone. So that's the sort of the axis. So I come back to the original point I made, that testosterone's floating around the blood stream, where it's finding prostate cells and prostate cancer cells if they're there, and feeding ongoing growth and proliferation. So we need to manipulate that, and that's what we do in our daily work. It's what you do when you're giving LHRH analog injections. We need to manipulate that, so switch off that driver, if you like. And the main way that we do that is, number one, we remove the source of testosterone, and I've numbered there various points. Those are not all the sources of testosterone, because the testosterone is not coming from number 2 in the brain, but they're points where this system could be manipulated. This is the most common way we do it. That's a picture of Charles Huggins, who won the Nobel Prize in 1941 for working out the relationship between testes, testosterone production, and ultimately carcinogenesis as well. And these are the most common ways we do it. And as you know, and as we refer to, orchidectomy was the original way of doing this. It's the gold standard. These days, we don't tend to, no, we sometimes still do, but rather than surgical castration on the left, we tend to use medical castration on the right. Now, I know there's been a lot of debate this morning, and I'm going to just touch on castration in a short while. I think the point I want to make at this point is, we know that if you do an orchidectomy, we are surgically castrating patients. We also know that if we give the drugs, we are trying to achieve the same biological or biochemical outcome in order to help treat the prostate cancer. So that's medical terminology about what the drugs are doing, which I think is very different from the way you might necessarily speak to a patient. There's biologically understanding what is happening, and of course we all need to know what we're actually doing to the men, because they have to deal with the sequelae of it. The fact that that's medically what we're doing does not necessarily mean that we have to use those words in exactly that terminology, or at least that's my view, but maybe I shouldn't open up the earlier debate. So having covered that, this is the American Society of Clinical Oncology guidelines, so something by which, so a recommendation from a hallowed group of healthcare professionals who sat around and worked out what, using the current available best evidence, is the optimal way of treating prostate cancer. LHRH analogues are standard initial therapy. The reference at the bottom, which absolutely does not need to be written down, is the main meta-analysis that was used to reach this. It is not the reference for the actual paper. Now, so we know, because you all do this in your routine daily work, that if you give LHRH analogues, so Prostate or Zoladex, we know that there is something called a flare. And we know that because we have to give an anti-androgen, so something like cyproterone acetate, what I use locally, but you might use Castadex, to protect the patient against the flare. Now, what that means is that the LHRH analogue is, if we go back, and I should have put it in here, I haven't, so I'm going to flip back, but the LHRH analogue, an analogue means it's like LHRH. So an LHRH analogue is like LHRH. So if you give an LHRH analogue, we already know that LHRH up at the top is stimulating the production of testosterone from the testes here. So if you give a drug that's like LHRH, it does exactly that. It stimulates a whole load of testosterone production. So that's why we need to block the effects of that with the initial drugs that we use. We need to give an androgen or a testosterone receptor inhibitor. Because if you don't, you can make the prostate cancer worse for a while, and there are certain conditions that we'll come on to where that's a really, really bad idea. So we have to block that. Now, the reason LHRH analogues work is that in the normal system, when the brain is making LHRH, it makes it up and down throughout the day. So it's not a constant dose. It goes up and down, and up and down. If you give an analogue, the system is flooded with LHRH, or an LHRH-like thing. It's flooded. And the brain's response to being flooded and detecting the same constant high level of LHRH-like drug all the time is it shuts down, it loses its receptors. The receptors just shut down and stop being there, they don't detect it. And that happens fairly quickly, within a week or two, and then you can remove the androgen receptor blocker, and the driver between LHRH type drug in the system stops making testosterone from the testes. That's effectively what happens. And so when you give these drugs, most people respond. We know that. We've all seen the majority of people where the PSA does drop. Many will get a radiological improvement and a symptomatic improvement. And And in the first line setting for advanced disease, the response duration for that is around about a year and a half. The other drug that's used sometimes up front, either alone or in combination, is bicalutamide, which is an androgen receptor blocker. And effectively what that does is it acts at completely the other end of all of this, which is where this bit that I've said is inside the prostate cancer cell, when this interaction, which would normally lead to cancer cell growth, it blocks it, it stops this, I'm going backwards and forwards. It stops that from happening. So I'm not going to cover masses of data on which trials led to telling us those drugs work. We know those drugs work. I think it'd be more interesting, in the time that we have, to look at some of the queries around that. So these are the questions that I thought we ought to just touch on before we move on to some of the other newer therapies that we now use. So, are anti-androgens as effective as something like an LHRH analogue or an orchidectomy? And I thought I'd just cut to the chase here. So this is what the American Society of Clinical Oncology guidelines say. They say that a drug like bicalutamide can be discussed as an alternative, but we do not yet have the evidence to say that it is definitely equivalently effective, although it is less toxic in terms of libido, sexual function, and physical capacity and fatigue. And of course, those are very important things. It is not considered standard first-line treatment, but it is an acceptable alternative. Steroidal anti-androgens, so like cyclosporine acetate, which is actually fine to use for those 3 weeks when we're blocking against the flare response, are not as good as medical or surgical castration therapies and are not considered standard treatment. Should we use maximal androgen blockade up front? So should we be giving an LHRH analogue like Zoladex or Prostate together with an androgen receptor blocker like bicalutamide at the beginning? The theories on this are changing. So this is one meta-analysis of a huge number of trials over a huge number of years, all the patients pulled together. What happens? Well, this says that there is a small, very small survival benefit from giving both drugs together from the beginning. So men might live a little bit longer if you do both up front. I don't know if many of you do, as routine, give both drugs together up front ongoing. I suspect not, and I certainly don't. The toxicity is considerably greater, there is no doubt about that. And the survival benefit, if it does exist, is probably fairly small. So there are some more trials coming through that say, yeah, there may be a little bit of a survival advantage, but it's not clear how much or how conclusive that would be. And it's not something I do as routine, because the toxicity is quite considerable. We've already said that these men can live quite a long time, so you're subjecting them to toxicity potentially for quite a long time. So it's not considered routine, although there are steady trials that come out from time to time that say there's a little bit of a survival advantage, but there's quite a lot more toxicity. Immediate versus delayed androgen deprivation. I'm not going to go through the particulars, the survival curve as such, but more to the conclusion. So there is sometimes a thought, there are different situations here. There are, of course, men who might be on watchful waiting who are relapsing. There may be men who have had radical treatment up front and then they relapse later. There may be men who are diagnosed with advanced disease up front. Is there a benefit for immediate versus delayed androgen deprivation? For those, given sort of the title of my talk, which is advanced disease, for those men who are diagnosed with advanced disease up front, we pretty much generally would start immediate therapy. There is a bit of a survival advantage. There also may be symptoms, and if there are symptoms, then certainly I would say strongly that there is a role for immediate androgen deprivation. In the absence of symptoms, there are differing schools of thought, but if somebody has presented with, a fit man has presented with a metastatic prostate cancer, I know that personally I would find it very hard not to offer them treatment or not to suggest immediate upfront treatment, and that is my personal recommendation when I see men like that. There is a bit of a survival advantage, and also I don't particularly want to wait till people develop symptoms and become less well. I want to keep men as well as I can for as long as possible. That does involve obviously a conversation about the toxicities of treatment, but that's so there is an ongoing conversation. I think the setting of established metastatic disease, generally immediate treatment is the way I would go, say following a suitable conversation with the men involved. Immediate versus continuous androgen deprivation. Sorry, intermittent versus continuous. This is again a debate, and I'm sure we all have men who want to come off treatment from time to time because of toxicity and have breaks, and I do have men on scheduled breaks. The party line is that it's considered experimental, and that there aren't any validated, prospective, randomised data to support that it's definitely all right to do that. On the other hand, there are men in whom it suits, and we're not treating a set of numbers and data, we're treating real people. And so I think at times it is an appropriate thing to do, and you can watch the PSA go up and then treat and restart. And it is something that I do in my practice from time to time, not routinely, not with everybody, but I think we're treating real people, and it's important to have an individualised conversation. So I guess that's what I would say about that. Finally, on LHRH antagonists, finally on upfront androgen deprivation, I thought I should mention Digarelix, which I'm sure you know is one of the newer drugs. I'm sure some of you get asked about it by your patients. And the main difference is this is an LHRH antagonist, not an analogue, so it works slightly differently. And the key facts for us is that it suppresses the testosterone levels very, very rapidly, so within a matter of a few days, as opposed to a matter of several weeks. And that very rapid testosterone suppression without any flare response can be, is potentially beneficial for men who are at risk of having increasing symptoms or worsening cancer or potentially worsening severe sequelae if there is a risk of them progressing with that flare response. The most cited example being those with actual or impending spinal cord compression, and I actually used my first dose of Digarelix for exactly that last week, having finally got through the Drugs and Therapeutics Committee and all of those various hurdles. So I think that is the role, and it is being treatment is being used increasingly. And that's a graph that says that, I won't go through. I just put this in to remind me to say that there are, if we were treating women with breast cancer rather than men with prostate cancer, which in many ways are similar diseases, clearly they're different, but many of the similarities, early chemotherapy would be routine for many people. We don't know whether it makes a difference in prostate cancer, but there are questions around that, and some of you will be aware of patients with the Stampede trial, where the use of additional upfront therapies is being looked at. And I think it's an important question. I think it's important that we have more and more clinical trials for these men who have been under-researched in the last 10 to 15 years in comparison with some other diseases. I don't have time to talk about toxicity of treatment, but this is really just to say we all know that all these treatments that I'm talking about, survival advantages and so on, do have significant side effects for the men involved. And we've heard quite a lot about that already. So all of these conversations incorporate a conversation about what the effect this is likely to have on men. I'm not going to go through that in any detail now, but I just think it's important to reflect on that. What do we do when our first treatment stops working? So this is where I want to mention castration resistance. What do we do when it stops working? We need to think about second-line therapies. So as I say, castration resistance, as far as I'm concerned, is an important word to terminology to understand because it is different than hormone resistance. But it doesn't mean that I say to a man who's come to clinic, oh, I'm sorry your PSA is going up, that means you're castration resistant. I hope I have never said that. I really don't think I have. But what castration resistance means is it means progressive prostate cancer despite castrate levels of testosterone. We increasingly know that these men can respond to subsequent hormonal therapies, which is why in the literature and why in clinic and in general, chit-chat, We don't talk as much these days about hormone-resistant prostate cancer. We talk about castration-resistant prostate cancer, because these men are not resistant to hormone therapies. And of course, we're giving them hormonal or endocrine therapies, so they're clearly not completely resistant to hormone treatment. So that's really why the terminology has changed, because we have to acknowledge that these men continue to respond to hormonal manipulation. The thing that stopped working is just making them medically or surgically castrate. That in itself is no longer a treatment. I think this is my only other sciencey slide, but I think it is. This is just a little bit of science. Why does it stop working? What is actually going on in that prostate cancer cell? Why this treatment that's worked so beautifully and brought the PSA down from, I don't know, 2,000 to 2, worked so brilliantly for an amount of time, what has gone on to stop it from working? I'm sure people ask you, why isn't it working anymore? Well, I can't totally answer that, to be honest, but basically, what seems to be apparent is that the androgen receptor has gone wrong, so it's not working quite right anymore. It has changed. And it can change in a whole host of ways, and I've listed some of them there. But I think the important thing is the androgen receptor has started working differently. And then maybe it can be activated by other things. It is working differently. And that's mostly the crux of everything that happens next. Okay, I lied. That's clearly another science slide. Didn't mean to, sorry. The point of this is not to know any of the molecules or anything like that. The point is to say that on the left is what happens normally up here. That's what happens in your castration-sensitive, hormone-sensitive upfront patient. And what this is telling you, the message here, is that the cancer cells are clever. They find other ways of stimulating the cells to grow and divide and grow and divide and grow and divide. There are all sorts of ways. I could change those letters for different molecules. There are other ways of getting around it. So the ultimate bottom line, which is what we've seen here before, this transcription, cell growth and division, can happen for reasons other than the testosterone part of it. So the cell is clever, it finds ways around it. You all know this. We do aim to maintain low testosterone levels even when they've progressed. Even when men have progressed, despite their upfront LHRH analogue, we continue it, and everything else is added in on top of it, but we don't stop them. And this is one of the pieces of data that tells us that. That men tend to do better and live longer if we continue to maintain low levels of testosterone by continuing their androgen deprivation. So, I'm not going to talk about any of this lot because I think there are other more interesting things, but I thought we should list the conventional secondary hormonal therapies. Maximal Androgen Blockade by the addition of anti-androgen, then withdrawing that, so Castrate's withdrawal, which also, as you know, can have an effect. We can inhibit inhibitors of we can use inhibitors of adrenal androgen production. I'm going to talk more about that. We can use estrogens, and what they all do is they all alter the drivers that make testosterone. But if I'm going to do a full talk about treatment of metastatic disease, I need to mention chemotherapy. I hope all my patients are maybe not quite as young as that, but certainly as happy as that when they're having chemotherapy. I fear it may not be true, but anyway. We started off in chemotherapy for prostate cancer using mitoxantrone and prednisolone because of this study by Ian Tannock, published nearly 15 years ago now. And the bottom line of this was that if you gave the drug mitoxantrone with prednisolone as opposed to just prednisolone in men with advanced prostate cancer, they were more likely to get an improvement in their pain. That was the bottom line of the trial. So the story about chemotherapy in prostate cancer originates here. If you gave mitoxantrone, pain was more likely to get better. And that started off the field of chemo and prostate cancer. It was sadly, and again I can think about what might have happened in this 10 years in breast cancer. 10 years, almost 8 years anyway, till we got the next significant development, which was Docetaxel. So almost 10 years go by, and again Ian Tannock, the study of the TAX 327 trial using Docetaxel and prednisolone, which was compared with what was considered standard, mitoxantrone and prednisolone, even though mitoxantrone perhaps wasn't that widely used, that was the comparator. And it provided better pain control, better quality of life, and this improvement in survival, so 3 months. Average survival, 3 months better if men had Taxotere versus mitoxantrone if they had castration refractory prostate cancer. Now, that's not immense. We don't want to make people live 3 months longer. We want to make them live 3 years longer, or longer than that. So 3 months isn't massive. But it was the first significant survival benefit to a comparative trial of chemotherapy and prostate cancer, and there's a landmark trial for that. These are the updated data from 2008, but it's a landmark trial for that. And as I've said, it's not right for all men. It does have toxicities, but it's important that we consider it. It has moved the field forward. This is to show the reduced pain. It does reduce pain better than mitoxantrone reduced pain. We see graphs like that in clinic all the time, and is that enough to subject men to these toxic treatments? Is the rising PSA enough? We know. I mean, sometimes I worry I get fixated on PSA, and I know that a lot of my patients get fixated on PSA. And I tried most of yesterday afternoon for when I was in clinic, not to have my first opening gambit with the patient being, what's my PSA? Your PSA is this. There is more to the patient than their PSA. But sometimes that's what they want to know, and they don't want me to. I mean, I want to say, how are you? And they want me to say, your PSA is 2.5. There is more to the men than their PSA. And I think rising PSA, especially if it's rising very rapidly, is an important marker that things are going wrong and starting to go wrong quite quickly, potentially. But symptoms are very, very important as well. So, a wise man said to me once, the best day to start chemotherapy is the day before a man begets symptoms. I wish I had that crystal ball. So we use whatever we can, whatever knowledge we can to try and pick the right moment. And the right moment's different for different people. And for some people, that right moment doesn't come because that's not the treatment they want. But there is more you need to think about, more than just the rising PSA. And I've got a few more slides, I think, just mentioning some of the new treatments that I'm sure you're aware of that I wanted to mention, and developments post-Docetaxel. There are standard things we can try. We can maybe try some silpistrol or some prednisolone or some dexamethasone if we haven't done those things already. There are other palliative treatments, radiotherapy, radioisotopes, etc., etc. But I want to just talk for my final few minutes on some of the emerging data that's coming out of the new drugs. I haven't got to put in the slides on the Docetaxel re-challenge, but actually the Birmingham group have produced some really nice data on usefulness in certain circumstances of using Docetaxel again. Of course, it's not funded for most of us at the moment, so it may not be available, but I think it's just important to remember that it is a useful drug, and for men that respond well and tolerate it well, considering doing it again actually can sometimes be helpful. But then we've got some new exciting things. So, the TROPIC study is a study of men who had progressed during or after Docetaxel. Now, very, very, very many of these men progressed very quickly after Docetaxel. So this is not a group of men in whom Docetaxel worked brilliantly. This is a group of men in whom many of the Docetaxel hardly worked at all. And they had either cabazitaxel and prednisolone. Cabazitaxel is a new drug. I think the phrase is, it's a new semi-synthetic taxane. So that means it's a bit like taxane, it's a kind of a taxane, versus mitoxantrone. Mitoxantrone does work after Docetaxel, and there are some data, but they're all retrospective data. So there isn't a right answer. Most trials you think, what's the standard therapy? There isn't, I said on my previous slide, it's not really a standard therapy here, but mitoxantrone prednisolone does have an effect. It's fairly well tolerated and it's fairly cheap in the scheme of chemotherapy and some of the other drugs we're going to talk about. So that's what we use, that's what was used as a comparator. And against this new drug, cabazitaxel. And, sorry it's a bit skew-weight, but up in the right-hand corner, the men with cabazitaxel lived a little bit longer by a couple of months. What I think I haven't put in here is that there were some things about the trial that were maybe a bit disappointing. Their pain was no better. the survival advantage is massive. I mean, it's there and it is significant. The p-value's got some, a string of noughts there. But their pain control wasn't massively better. So whilst this is an important development, and whilst patients may ask about it, and not many of mine have, but a few have, it's perhaps not. I mean, I think it is an important development, but I think but maybe some of the other things we're going to see may change the field more dramatically. It is still chemotherapy after all. It does still have toxicities after all. So then we come to abiraterone, and as I said, adrenal androgens are important. I said this right at the beginning, and although I bypassed them in the diagram at the start of this, I did say they're important. The adrenal gland does make androgens, which also stimulate the prostate cancer cell. And they are not knocked out by the LHRH analog. So, that's another lie, that's science. I thought I'd taken that out, I really did. You know that moment when you think, I've got to do a talk, which one should I take out? I've got too many, I don't need this one. I suppose since it's there, I can't resist a bit of science. It does this, it inhibits this, there you go. It inhibits those enzymes with big red crosses on the left, the CYP enzymes. It inhibits an enzyme that's in the adrenal gland that makes androgens, including testosterone. So it's an enzyme, abiraterone is an enzyme inhibitor. It knocks out an enzyme that makes adrenal androgens. And we know that abiraterone makes the PSA drop, both in, although I'm talking post-docetaxel predominantly, these are pre-docetaxel patients, so abiraterone makes the PSA drop, and that's what that shows. So this is PSA change. What these pictures show is, over on the left-hand axis, 0 would be no change in the PSA. Each blue line is a bloke, different bloke. And that's whether the PSA went up above the line or dropped below the line. So that's how you look at those graphs. And what you can see, I like things like this, they're easy to look at, because the message is quick. There's a lot more blue below the line than above it. That means most men had their PSA drop, and in fact in some of them it dropped quite a lot. So that's the message of that. In post-chemotherapy patients, and this was the initial small phase 2 study, the PSA dropped by this is not all comers, this is not all blokes that might walk into your clinic. This is a fairly fit group of post-docetaxel patients, but nevertheless, almost half of them had their PSA drop by at least half. And response rate, that's radiological response rate, that's cancer looking better on a scan, happened in a quarter. And that response lasted for nearly 6 months. That's pretty good going post-chemotherapy. So that was the first phase 2 trial that later led to a bit of abiraterone furore in the media a year or two back. This for me is a really important slide. This is what it's all about. It's about making men better, making their symptoms better. Not for good, but for as long as you can. Now, it's not going to project brilliantly in this lecture hall, but what I want you to see is in the red dots, there's a difference between the amount of black and the white in the bone. So that's someone's spine. And on the left, there's a socking great big hole in that spine. And on the right is much more white. That means it's filled in and it's got better. Now, there is of course a massive danger in using anecdote to define clinical practice. And this is anecdote, this is a patient. What happens to a patient doesn't tell you it's the right thing to do for all men. The only way you can do that is with a proper randomised study. But this does tell you that for this man, he was in a blinking bad way when he was on the left, and he got a heck of a slight better by the time he was on the right. And what else it tells you is that this drug is doing some quite incredible things, really. So it's an important drug, and what we know is that the big study has now completed, and I think J&J are trying to trailblaze on their website, but the data are going to be released at ESMO in a few weeks' time. And this is the penultimate drug. I know, I'm sorry, I'm running overrun. MDV 3100 is basically fancy new Castadex. It's a bit like Castadex, it's an androgen receptor blocker, but it's a fancy, better, newer version of it. And this is a similar waterfall plot, and I couldn't get the colours right on this. anyway, so I'm sorry, but it's the same principle. The more blue below the line, the better. Most of the blues below the line. That tells you that these men's PSA dropped in a lot of cases. And more than rose. So there's a lot more blue below the line than above the line. The difference is on the left, pre-chemotherapy patients, on the right, post-chemotherapy patients. Sorry, the final thing to say about MDV is that a phase 3 study of that is recruiting at the moment, so we do not have randomized data on MDV. We have these early open label study data saying it's a drug that can make the PSA drop and can make men feel better when they've had progressive prostate cancer post-chemotherapy. The final thing I want to say about it is Provenge, or Cipuleucel-T. I'm still struggling to say that. I like to call it Provenge. So Provenge was used, and this is not post-chemotherapy, but I put it in just at the end because I think it's going to impact us, least of all of these things. It's immunotherapy, effectively. It's a vaccine treatment, and this was used for men when you might have considered Docetaxel. So they had progressive disease after androgen deprivation. And this tells you that it's complicated, it's tricky. What you do, and you do it at a centre in America at the moment, in one place in America, you take some blood out of the man, you send it off to the centre, they mix it around in a test tube, and then they send it back to you and you give it back to the patient. That is not straightforward. That is not writing a prescription and going to pharmacy. That's time-consuming, difficult business. It does some amazing immunotherapy. I just think it's like a Death Destroyer. It's zooming in and bringing all sorts of bright, flashy lights, and it's effectively what it's doing is it's hiking up the immune system in some way that is not understood to kill prostate cancer cells. So this is for men with advanced, but early-ish advanced prostate cancer. And they lived a bit longer. So this is a sort of slightly earlier than chemo. This is around about a chemotherapy type of patient, Docetaxel group of patients. Their survival benefit was 4 months, and that's longer than the Taxotere survival benefit over mitoxantrone, which was 3 months. So it's a 4-month survival advantage for the very realistic price of $90,000 for a cycle of treatment. And NICE aren't going to fund that anytime soon, I don't think. On the one hand, it's a proof of principle. It's a proof thing that a lot of people have put a lot of energy in over many years, that immunotherapy and vaccine therapy may be important and perhaps has a role in prostate cancer. It does, because this is vaccine treatment making people live longer. But we're going to have to find an easier way of doing this. And I'm sure it will develop. So I think it's a very, very important message. But not many of us are going to have found £90,000 or dollars rather anytime soon. I have 2 slides. This was a treatment post-Docetaxel. That's this chap's PSA going up and down over, as you will see, 688 days after failing Taxotere chemotherapy. So we're talking 2 years. And with this treatment, PSA went down, and then he might come off it for a bit, and it went down, and then the PSA would go up, so he'd start it again, and it would come down. And then he stopped it again, he didn't like it much, but he liked the effect, he liked the shape of the graph. So it would go up again, and then he'd start it again, it would come down. And then it was down, didn't like the treatment, he would come off it again. And we've been doing this for a few years. And this is prednisolone, 10 milligrams a day doing this. And so this has been controlling this chap's PSA cyclically. And there's no trial telling you that this is brilliant, or that intermittent prednisolone is an ideal treatment post-prostate cancer. And again, it's anecdote, and I'm not advocating treatment by anecdote, but just to say that it is individual. There are lots of different things that work. This is my final slide. So we went from 1941 with Charles Huggins giving us androgen deprivation therapy to 1996. Ian Tannant's trial of mitoxantrone, bit of zoledronic acid, which is, I haven't discussed the debate around zoledronic acid, there is one. Docetaxel, and then suddenly you're getting all sorts of new and exciting treatments, and we don't know quite the effect of these, but I suppose the message being that actually it's good that we are developing lots more trials for these men who have been under-researched, and actually that history lesson in terms of the gaps between significant developments, I hope is going to get very much less in the coming years. So that's the end. Thank you very much.
Lisa, thank you very much. A real tour de force. You certainly covered everything for us there. Now, we can take questions, or you can be mindful that when we come back from lunch, we're going to be moving on to case-based discussions of just this sort of patient. Will you be staying after lunch, Lisa? Maybe in clinic, yes. If there's any pressing questions for Lisa.
Some off lunch, but I won't get by the afternoon.
So perhaps catch Lisa over lunch if you've got specific questions. Otherwise, I suggest we break there.